Hello, my name's Casey Clarkson. I'm an internal medicine resident at Dalhousie University. In the next few minutes, I'd like to share with you some thoughts and strategies for approaching discussions about resuscitation or code status with your patients. This is an issue that is important and relevant in many disciplines of medicine. Before we get underway, I'd like to acknowledge that discussing a patient's goals of care and resuscitation can be a challenging and even daunting task. Unfortunately, there is very little teaching material available to introduce you to the necessary skill set. These discussions are every bit as much an art as they are a science, and there's no single right way to go about them. This video is intended to get you thinking about the challenges and to offer some suggestions based on my own experience and some of the existing literature on the topic. It's not meant to be an exhaustive resource on the subject. By the end of this video, you should be familiar with the concepts of code status and goals of care. You should be able to identify the key elements of a good code status discussion. And you should recognize the importance of clearly identified goals of care and resuscitation guidelines to good patient care. You should also have developed a basic approach to initiating a discussion about resuscitation. A code status is a set of instructions about how far to proceed with resuscitation in the event of a patient's sudden, unexpected, and acute decline in heart and/or lung function. The name comes from the term code blue, which designates a cardiac arrest on a hospital inpatient. In the simplest situations, patients are either designated as full code, i.e., healthcare workers should proceed with all appropriate resuscitative measures, including CPR, or no code, often referred to as a DNR, or DNAR, meaning do not attempt resuscitation. Sometimes there are limitations set on specific components of resuscitation. Depending on the patient's illness, it might also be appropriate to include instructions about related life-supporting measures, such as admission to the ICU, use of inotropic drugs, use of non-invasive face mask ventilation, such as BiPAP, or hemodialysis. It's important to recognize that in the absence of a no-code order, the default protocol for a hospital inpatient is to proceed with full resuscitation. CPR stands for cardiopulmonary resuscitation. It serves as a bridging measure to support heart and lung function in a critically ill person unable to circulate blood and/or breathe effectively on their own. At its most basic level, CPR involves chest compressions to circulate blood and some form of respiratory support, such as mouth-to-mouth respiration or bag mask ventilation. In a hospital code, we might also use more advanced airway management, such as endotracheal intubation, and electrical cardiac defibrillation, as well as a multitude of intravenous drugs. It's important to discuss code status because not every patient would benefit from CPR, and not every patient would want it. Some people feel very strongly that they should have every possible opportunity at survival. Others are adamant that they would not wish to be on life support and would prefer to die naturally. Having a meaningful and direct discussion about a patient's resuscitation status respects the autonomous person's wishes and values about how aggressively they would wish to be treated should they become critically ill. In doing so, it can improve a person's satisfaction with the care that they receive. It also serves as an important opportunity to address broader issues around the overarching goals of care for the patient. The literature reveals that the most important factor determining whether or not a code status discussion occurs is the physician's willingness to address the issue. Therefore, as doctors, we must assume responsibility for initiating these very important discussions. There are no set rules that guide us as to which patients we should broach the topic with. A 2000 JAMA article by Quill makes some suggestions on the issue, and they propose the following situations that they deemed urgent indications for discussion of resuscitation: when a patient's death is imminent, or when they're suffering severely and have a poor overall prognosis. They also suggest that when a patient indicates a wish to die, or inquiring about palliative or hospice care, that the issue of code status should be visited. Another urgent situation would be for a patient who was recently hospitalized for severe and progressive disease. Other opportunities to initiate the conversation might include a patient who faces a real threat of cardiorespiratory failure, or as a part of any discussion about a patient's prognosis and a treatment plan, and during discussions with patients known to have terminal illness. In the world of adult medicine, with the aging population that we serve, it is almost always reasonable to address the issue of resuscitation. This is particularly true for patients being admitted to hospital, since the inpatient population are at significantly higher risk of cardiorespiratory arrest. I often tell my patients that I would rather have 100 conversations about code status and never need to know their outcome than to face one situation in which I need to know the patient's wishes and don't have the information to guide my actions. Before undertaking a discussion about code status, you should ensure that the patient you will be speaking with has the capacity to make the decision. This assessment usually takes place informally, and most often you will have developed a sense based on your encounter to this point. Remember, a person's capacity, unlike their competency, is relative to the decision itself. Someone may have capacity to choose their breakfast cereal, but not to arrange their financial affairs. To have capacity in deciding resuscitation status, a person must demonstrate that they understand the fundamental concepts of resuscitation and what their options are, that they appreciate the risks and benefits of a decision one way or the other. They must also be able to justify their decision and to be able to communicate their decision clearly. Ideally, every person would be able to clearly communicate his or her wishes on the issue of resuscitation before becoming critically ill. Some people have informal discussions with their loved ones on the issue, and others draft documents called advance directives or living wills to spell out exactly what they would and wouldn't want done in their medical care should they become very ill. All too often, the person for whom the resuscitation decisions pertain is unable to decide for him or herself, either because they lack the capacity to do so or because they are unable to communicate. In these situations, we seek input from the patient's substitute decision maker, sometimes shortened to SDM, and also called a proxy, who is most often a family member or other loved one. Who is the most appropriate substitute decision maker from a legal perspective can be a complicated issue and is beyond the scope of this video. However, regardless of who the proxy decision maker is, it is crucial to remember that their role is to clarify what they believe the patient would have wanted for him or herself, and not to impose the proxy's own values. Their decision should take into account the patient's previously known and expressed value set, their cultural and religious aspects, and the patient's prognosis. Earlier, I reviewed some suggestions about which patient situations might warrant a discussion about resuscitation status and goals of care. When it comes to timing, generally speaking, the sooner the better. Remember that it is best to have these conversations in a calm setting with lots of opportunity for discussion. Waiting until a patient is on the brink of crashing is definitely less than ideal. It has been my practice, whenever possible, to broach the topic with every patient and their family at the time of hospital admission. This is usually when I've spent the most time developing rapport with the patient and ensures that the issue won't be deferred or inadvertently forgotten altogether. In the outpatient setting, such as in an oncology or palliative care scenario, the best timing should be determined on a case-by-case basis.